is which is dependent on the solubility of the anesthetic in the blood. If an agent has poor blood solubility, the amount of gas needed to saturate the blood is small and brain saturation occurs fairly quickly. So I think this actually explains it. Just scroll down, Dr. Satorov. I think this has explained the difference in the graph and why. So wait, I think this is where we should have even started reading from, Dr. Satorov, the graph, the table. Characteristics of gas anesthetic. I think we should note this. So the effect is the amount. First of all, we have the amount needed to saturate the blood. Polysoluble gas, we have nitric oxide and highly soluble gas, example halothane. uh Characteristics of gas anesthetic. So in polysoluble gas, the amount needed to saturate the blood is small. Like nitric oxide, the amount you need to saturate the blood is small, but highly soluble gases like halothane, we need a large amount to saturate the blood. The rise in partial pressure in blood will be rapid in nitric oxide, but it will be slow in halothane. Looking at the graph, you can see it's the time, like, yeah. The equilibration with the brain, it will be rapid in nitric oxide, but it's going to be slow in halothane. And the onset of action of effect in polysoluble gas like nitric oxide will be rapid, but it's going to be slow in halothane. Do you understand the onset of action? Option A, D, and E is literally the effect of nitric oxide. Nitric oxide is an example of gas with relatively low solubility in the blood, characterized by rapid onset of action and fast equilibration with the brain. Choice C, the potency of a gas anesthetic is determined by the minimal alveolar concentration. It is defined by the concentration of the gas that produces the desired effect in 50% of the patients. So the objective, the onset of action of a gas anesthetic depends on its solubility in the blood, and the drug with high blood gas partition coefficients are more soluble in the blood and demonstrate slower equilibration with the brain and have longer onset times. So if you cannot remember, basically with the inhaled gases, right, the inhaled anesthetics, you differentiate it with nitric oxide because it's like the odd one out. So just remember that nitric oxide is low, it has low solubility, it's fast act is rapid action, like the onset of action is rapid, equilibration in the brain is rapid, but you need a small amount to saturate the blood. The rest will be large amount to saturate the blood, and they are slow. If that makes sense. Sometimes the way I put things in my head is just different. But I hope it's understandable, if that makes sense.
Hello, hello.
Hello, Dr. Satorov. I'm so sorry, Dr. Ahmed. Do you want to
Okay,
explain?
okay. So actually, let's just start our class. Okay. So
Yes,
we have
please.
like yes. So we have CNS tumor remaining, and with that, we'll be finishing off our neurology, and right after that, we'll be starting our special senses, that is eye today, right?
Okay.
After, hello.
Yes, Dr. Ahmed, we can hear you now.
Okay. So let's have 5 minutes of break. We'll be starting our class, right?
Okay. Thank you.
Okay.
Okay.
Thank you.
Dr. Satorov, you can stop sharing your screen. You can stop presenting. We'll have 5 minutes break then, Dr. Ahmed's lecture. Okay.
Hello? Hello? Can you guys hear me?
Yes,
Yes.
hello, Doctor.
Okay. Okay. So today we are going to discuss our new topics that will be special senses. We'll be starting with eye, and it's very important. Believe me, like basically the eye module is for your step two. But most of the students of step one do not understand different structures, the commonly occurring diseases. I'll try my best to make it as simple as possible. So let's start our today's discussion, right? So we'll be starting with our first discussion, that is CNS tumor, right? Okay. So remember, in CNS tumor, basically we have two types of tumor, right? One are the primary tumors which occur within your CNS, that are primary tumors, and your metastatic tumors, right? Metastatic tumors. Okay, I think I haven't shared my screen. Okay. Yes. Okay, let me just share it. Can you guys see it now? Okay, perfect. So we have primary tumors that
Yes.
arise within the cells of your central nervous system, and we have metastatic tumors. So the metastatic tumors basically comes from different parts, right? And the common parts which metastasize to your CNS, or the common tumors which metastasize, are your tumors of your kidney, tumor of your, yes, your breast, and lungs, right? Yes. So these three tumors would love to invade your CNS. And 50% of the tumors are believed to be primary, while 50% are metastatics, right? So the primary tumor basically depend upon the cell type, right? So we are already aware of the different cell types which are present within the CNS. So based on those cell types, we have primary tumors, and let's discuss that. We already know that in our CNS, we have some supporting cells, like, for example, the glial cells. We have astrocytes, we have oligodendrocyte, which myelinate your central nervous system. We also have ependymal cells. You guys are already aware of that. We have neurons, the basic functional unit of your CNS, right? So all of them can give rise to certain tumors. So let's discuss that. For example, we have astrocyte, right? Astrocytes. We have our oligodendrocytes. We have our neurons, and we have our meningeal cells, right? All of these cells are basically present within the central nervous system. Remember, it's very important to know that which cell type give rise to tumors, but the age group is also important, right? So we can have like tumors within the children, and we can have tumors within adult, right? Remember, it's a common thing which you guys should know. We know that our dura mater basically separates certain parts of your brain. You guys are already aware of that. The dura mater, which form the falx cerebri, if you guys know, it would separate your right hemisphere from left hemisphere. You also know that we have tentorium cerebri, right? Like below the tentorium cerebri, you have cerebellum, and above the tentorium cerebri, basically you have your cerebrum, right? Remember, in children, the tumors would always arise below the tentorium. Remember this point, right? The tumors in children would always arise below the tentorium. And tumors within the adult mostly arises within your cerebrum. Okay, so I want you guys to answer me a question. What is the exception? What is the tumor in children which arises above your tentorium? Yes, you guys already know that. The only tumor which arises above the tentorium within children. Yes. Perfect.
Craniopharyngioma.
Craniopharyngioma, we already know that. We'll be discussing in detail as well. Craniopharyngioma, which arises from your Rathke's pouch, is the only tumor in children which arises above the tentorium. And whenever in your world question, you see tumors arising below your tentorium, think of children, right? Okay, so the astrocyte tumors can occur in children and both in adult, right? So the tumors, like the primary tumors, which are like due to proliferation of your astrocyte, which occurs in children, are known as pilocytic astrocytoma, right? Pilocytic astrocytoma, right? And the word pilo basically means that you guys are already aware of that. The astrocytes are a kind of star shape of cells, right? So the pilocytes are simply, like these here kind of projections, or the food processes of astrocyte. They are star kind of cells, which also helps in formation of your blood-brain barrier, right? So that's why they are known as pilocytic astrocytoma, right? While whenever the astrocyte, like, give rise to tumors within the adult, that would be known as glioblastoma multiforme. Is that clear? Hello?
Yes.
Yes, sir.
Yes, we can hear you.
Okay, perfect. Okay, so the next kind of cells are your oligodendrocyte. We are already aware of that. Oligodendrocyte helps in myelination of your central nervous system, right? So these tumor, for example, if you have tumors that are originated from your oligodendrocyte, so in children we do not have tumors of oligodendrocyte. It only occurs in adult. Why am I discussing this children and adult group? Because whenever in the U World MCQ you see children, child, or adult, you can rule out a lot of options based on this chart. So you guys should know that, right? So oligodendrocyte do not give rise to tumor within the child, within like the small age group or child, right? So it would give rise to the tumors within adult, right? That is oligodendro. Yes, what's the name of that? Oligodendro
Glioma.
glioma. Yes,
Glioma.
perfect. Oligodendroglioma, right? Okay, so in the neurons, we are already aware of that neurons do not divide within your central nervous system. You already know that, right? So the tumors which arises in the neurons would only be seen in children, because in the children or the child age group, the central nervous system neurons basically divide, while in the adult, the neurons do not divide. If you damage it, you cannot even regenerate it. You already know that, because the oligodendrocyte do not have ability to regenerate your neurons. Is that clear? So then tumors which arises from neurons would only be seen in children or child age group, right? And the name of that tumor would be medulloblastoma, right? Medulloblastoma. Is that clear? And where it would be present? Below the tentorium, by the way, okay? Within the cerebellum. Is that clear? Hello?
Yes, yes.
Yes.
Okay.
Yes.
And your meningioma would arise in the adult age group, right? Meningioma. So whenever in the U world you see tumors, and you must look to the like the age group, right? If they are children, so you can only imagine of astrocyte. Okay, what about ependymal cells? Yes, tumors can also arise from ependymal cells. And remember, the ependymal cells would only give rise to tumor within the child or the children age group, right? Within this age group. So that would be known as ependymoma. Is that clear? So whenever in the
Yes.
you are just seeing like questions of tumors, first of all you must look at the age group, right? So if it's the children, so you should only think of these two tumors. We'll be discussing in detail their feature, histopathological findings, and whenever you have adult age group, think of these tumors. Is that clear?
Yes, sir.
Oh, okay. Okay, perfect. So let's take our discussion a little bit further, and let's discuss our first CNS tumor, that is glioblastoma multiforme, right? GBM. As we already know that glioblastoma, okay, remember, glioblastoma is the malignant tumor, and pilocytic astrocytoma, whenever it occurs in like a child age group, it would be benign, remember, right? So GBM, basically, we already know that it's a malignant tumor of astrocytes which occurs in adults. Is that clear? What else? As we know that it's malignant, so it would just tend to spread, right? It would tend to spread. And we already know if it's a tumor of adult, it would occur within the cerebrum, right? Above the tentorium. Is that clear? So if it's malignant, it would obviously spread. And remember, you have a characteristic feature of this tumor. For example, if this is your cerebrum, let's suppose if the tumor occurs at the left cerebral hemisphere, okay, let's suppose this is your right cerebral hemisphere. So it would tend to spread for example, if you have GBM or glioblastoma multiforme here, so it would just spread to your other lobe, right? For example, if it's present in the right, so it's basically malignant. Its ability is to spread, so it would tend to spread through your other lobe, that is left lobe, right? Through a structure which is known as corpus callosum. You guys are already aware of corpus callosum. It's basically connection between right and left hemisphere. Is that clear? So it would just give rise to a characteristic feature, that is butterfly-like lesion, right? butterfly, like tumor or lesion, right? So it would just like resembles a butterfly whenever it's spread from one cerebral hemisphere to another cerebral hemisphere. Is that clear? Through corpus callosum, remember, right? Okay. So, for example, if we zoom in the picture, so what happens on your histopathological slide? What would you see? You would see an area of necrosis. You'll be seeing an area of necrosis, and the highly malignant tumor cells would be surrounding that necrosis. Remember, right? So it would surround the necrotic area, and this arrangement is basically known as pseudo-palisading, right? Pseudo-palisading. The word palisading basically means that the tumor cells would surround or it would palisade around the necrotic area. Is that clear? So you have a lot of keyword MCQ that will be giving you a slide. You'll be having, a pinkish kind of necrotic debris, and blue cells would be surrounding, right? And they'll be asking you that this histopathological image is specific to which tumor. That is basically glioblastoma multiforme. You have a lot of MCQ on that. Is that clear? Hello?
Yes. Yes, sir.
Okay.
Yes, sir.
Perfect. So if it's a malignant tumor, can you guys just tell me what do you think about the prognosis?
It's
Very
bad.
poor.
Poor.
Very
Yes.
poor.
Poor.
Yes.
Less than
They'll be
1
having
year.
a poor
Bad.
prognosis. Yes. Less than 1 year. Perfect. Right. And these cells would be GFAP positive, right? GFAP positive. Okay, just give me a second. Okay, just give me 1 minute, right? Hello? Can you guys hear me?
Yes, we
Yes,
can.
sir.
Okay, there would be GFAP positive. What else? On the histopathological slide, you are going to see another thing as well. That is the blood vessels. Within this slide, you are going to have proliferation of the blood vessels, right? So we are going to have a lot of blood vessels as well, right? So these are basically the histopathological features of glioblastoma multiforme. Is that clear? And in which area most commonly we are going to see this tumor? Remember, we are going to see it in 3 areas, right? So it basically involves the frontal lobe, it involves your temporal lobes, and your basal ganglia, right? So these are the 3 locations which, most probably you are going to see the tumor here. Is that right? And what would be the presenting feature? The idea is really clear. You'll be having a person who would experience headache, he'll be experiencing seizure, and that's obvious. For example, if you have a tumor, it would disrupt the electrical impulses, which would give rise to seizure, right? And most importantly, if an individual is having this tumor and if he's bending or if he's doing Valsalva, that is, if he's increasing his intracranial pressure, it would cause headache. It would just, exacerbate the signs and symptoms of headache. Is that clear? Hello?
Yes.
Yes.
Okay.
Yes.
And within these tumor cells, we are going to see another thing as well. One of your UWorld MCQ, that is, we are going to have increased expression of your epidermal growth factor receptors. So if we have increased epidermal growth factor receptor, due to this increased receptor, there is increased, like malignancy or increased division rate of this tumor. Is that clear? Epidermal growth factor receptors. Is that clear?
Yes.
Hello?
Mhm.
Okay. Okay, perfect. So let's discuss our next tumor, that is meningioma, right? Meningioma. Okay, so we already discussed that this kind of tumor would basically arises from the meninges. And where from the meninges it would arise? It would arise from the arachnoid cells. So from the arachnoid cells, the meningioma is going to arise. And remember, meningioma is also a benign tumor, right? So it means that you'll be having a fixed firm mass that won't spread your brain tissue, right? So we are going to have benign tumors. And remember, it is the most common tumor seen in women, right? Women. Okay, so what would be the features of meningioma if it occurs in an individual? What would happen? Due to the tumor, it would compress the surrounding brain area, and due to that compression, it can also give you like, for example, it can appear in the form of, like seizures. It can disrupt the electrical activity, and that's some common thing which you guys have to know, right? So the histopathological slide is very important. Histopathology is very important, right? So what would you see in histopathology of meningioma? You are going to see wall pattern, right? Wall pattern. So you're going to have two MCQs in your U world, and whenever you see this wall pattern of cells, just think of meningioma, right? You should also look towards like gender as well, right? In women. From the arachnoid cells, we are going to see wall pattern. And what else we are going to see? We are going to see samoma bodies as well. And you guys are already aware of what are samoma bodies. They are basically calcification seen within this tumor, right? So some of the parts of this tumor can be calcified, and after the calcification, we are going to simply name it as samoma bodies. Is that clear? So three things which you guys should just keep in mind. It's a benign tumor. It won't invade. It arises from the arachnoid cell, basically in women, right? You won't see it in children. We already discussed that, right? So what happens? It's going to it would be attached to the dura membrane as it is arising from the arachnoid cells. So we are going to simply see within your CT scan. They're going to give you a picture. It would just attach to the dura. And on histopathology, we are going to see wall patterns and samoma bodies. That's all. Is that clear?
Yes.
Hello? Okay.
Yes.
Let's move to our next tumor, that is schwannoma, right? So we are already aware of schwannoma, that basically they are tumors of your Schwann cells. What are Schwann cells? They basically myelinate your peripheral nervous system. And we are already aware of that in neurofibromatosis too. We see schwannomas, if you guys remember, right? So the schwannomas basically tend to spread within your internal acoustic meatus, and it would spread to your cerebellopontine junction. You already know that, right? Hello?
Yes, sir.
Yes. Yes, and in the cerebellopontine junction, which nerves do we have there? Which nerves can be compromised within the cerebellopontine junction? Yes.
8,
Facial and the
Five.
vestibulocochlear.
Eight,
Seven,
Seven,
5, 7, 8.
5.
and 5. Perfect. So it can involve 3 nerves. Remember, 8. If 8 is involved, we are going to have sensory neural deficit. We can also have problems with the balance. If the 7th is involved, that is your facial nerve, right? So we can see signs and symptoms of facial deficit, facial nerve deficit, and cranial nerve 5, right? Is it clear? Okay, what other tumor do invade CP angle? Yes. Yes. What do you guys think?
Meningioma.
Yes, we also have another tumor which also tend to, occur at CP angle. Yes. We discussed it recently.
Neurofibromatosis type 2.
Vestibular
Okay.
schwannoma.
Okay, we already discussed vestibular schwannoma besides
Sorry,
vestibular schwannoma.
Pioneer.
Meningioma.
Meningioma. Perfect.
Meningioma.
The idea is really clear. For example, if this is your tentorium, right? You already know that this is your tentorium. Below the tentorium, you have your cerebellum, and here you have your cerebrum, let's suppose, right? So the tentorium, we already know, is made up of dura matter, right? So from the dura matter, we already discussed we can have meningioma. And this meningioma can also, invade your CP angle. And again, it can compromise these 3 nerves. Is that clear? Okay. So we have special surface markers for schwannoma. Yes, what are they? We already discussed that in our class.
S100.
S100 positive, perfect. And in which other tumor do we see S100 positive?
Melanoma.
Melanoma, perfect. Melanoma, that's perfect, right? So let's discuss our next tumor, that is oligodendroglioma, right? So we discussed what are oligodendrogliomas. Okay, oligodendroglioma, right? So we discussed that these are basically tumors of your oligodendrocytes. And remember, they are malignant tumors, right? Malignant tumor in which age group? Children or adult? Yes,
Adults.
Adult.
adult. Adult. Perfect. So what happens in oligodendroglioma? It basically involves your frontal lobe. You guys must know that, right? It basically involves your frontal lobe. And what would be the histopathological features? Like, the histopathology is very important if you want to know these tumors, right? So we'll be having egg fried appearance. So what is egg fried appearance? Yes. Egg fried appearance.
Round
anyone-
nuclear cytoplasm.
Okay. Okay. So what happens that we are going to see like calcification of these tumors. That you are going to have a central nucleus, and surrounding this nucleus will be having like an area of a whitish kind of area within the your histopathological side, which would just resemble a fried egg, right?
Yeah, it's
Fried,
flying pen.
right?
It's
Yes.
like flying pen, egg flying pen.
Yes, perfect, right? So, what else we are going to see this tumor within the white matter? The idea is really clear. Why? Because oligodendrocyte basically myelinate your your tracts within your central nervous system, and those myelination it gives white appearance. That's why we also call it as white matter, right? So whenever you see like tumors within the white matter, think of oligodendroglioma. Is that clear? Hello?
Yes.
Yes.
Okay. Okay, perfect. So let's discuss. Okay, so these histopathological features are very important. You guys should know that, right? Okay, let's discuss our next tumor, that is pilocytic astrocytoma. Pilocytic astrocytoma. We already discussed that pilocytic astrocytoma is basically a benign tumor seen in children, and they arises from astrocytes. You already discussed that, right?
Yes.
Okay. So they are basically benign tumors. Okay, if it occurs in children, so it would be supratentorium or infratentorium. Yes,
Infratentorium.
Infratentorium.
infratentorium, right? So we are going to see it infratentorium,
Tentorium.
right? That is within the cerebellum, right? Okay, perfect. So basically, the pilocytic, what would be the appearance of pilocytic astrocytoma on CT, right? So pilocytic, you can simply imagine it as okay, or you can call it as pilocystic, right? Because this word is going to help you remember the structure or the cyst-like structure which it is going to form within the cerebrum, right? So we are going to have a cyst-like lesion, and surrounding that lesion, we'll be having, like a tumor or a dense area which is surrounding, or it's also known as mural nodule, right? So we are going to have a nodule or a node-like structure which is going to be attached at the mural or the wall of this cystic space. Is that clear? So pilocystic astrocytoma, just remember it like that. So a cyst, and surrounding the cyst or at the membrane of the cyst, we are going to have a nodule which is known as mural nodule. Is that clear? Hello?
Yes, sir.
Yes.
Okay, and on biopsy, we are going to see rosenthal fibers. So what are rosenthal fibers? Do you guys know that?
Yes, it's like a hair with follicles, like hair. It's like
Okay,
small and long. It's just
okay, perfect. So as we know that these are the tumors of astrocyte, so on biopsy, it would appear as a corkscrew, like a corkscrew appearance or a flower kind of, appearance. They basically call it as like, a flower kind, okay? Or a corkscrew is very specific, right? So in your word, you are going to have an MCQ corkscrew shape, eosinophilic. That is, it would be appearing as pinkish and corkscrew kind of, right? So they are basically known as rosenthal fibers. Is that clear? And again, these cells as well are going to be GFAP positive, right? Is that clear? So rosenthal fibers are simply corkscrew-shaped eosinophilic inclusions or eosinophilic bodies present within the histopathological sites of these tumors. Is that clear? Hello?
Yes.
Yes.
Okay. Okay, perfect. So let's
Sorry,
discuss.
Dr. Ahmed, if you don't mind, This question. What does it mean GFAP positive?
Okay, so basically, whenever we have like the glial cells, specifically astrocyte, they have like a specific markers for them, which is known as GFAP, right? GFAP. It's a marker for your astrocytes, right? So whenever you
Okay.
have like astrocytic tumor, like for example, if it's either GBM or if it's either your this pilocytic astrocytoma, so it would be GFAP positive, right?
Okay. Thank you.
Okay. It's simply a marker, right? Okay. So let's discuss our next tumor, that is medulloblastoma. So you guys are going to tell me what cells do give rise to medulloblastoma and in which age group. We already discussed that. Medulloblastoma.
Children.
Okay, children.
Neuronal cell.
Neurons.
Yes, neurons, neuronal cells, because in adults the neurons do not grow, right? So basically, it's a malignant tumor derived from granular cells of cerebellum. So we are going to see it in cerebellum. Why? Because if it's tumor of children, obviously they are going to present below the tentorium, right? That is within the cerebellum. Is that clear?
Yes.
Okay, perfect. So on histopathology, we are going to see a characteristic feature that is, yes, small, round, blue cells, and we are going to see Homer, right, rosettes. So what are Homer right rosettes? Can anyone just tell me? Yes. Yes, so you guys are going to tell me what are Homer right. Are you guys, have you guys did this topic before?
No.
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 Okay, so Dr. Mariam will just tell me. Dr. Mariam already I think know a lot of information.
So I think it's pathologically we see the rosette appearance. Um, uh, it's just cells surrounded. The central area is necrotic, and the small blue
Necrotic?
cells are surrounded, which is surrounded by small blue cells.
Okay, so is it necrotic or we are going to have
I think
neutrophils?
neurophils
Yes.
are in the because it is a neuronal in origin. The neuroblast origin. So we will have the neurophils in the center and the surrounded by the small blue cells.
Okay. So we are going to see it's neurophils or neutrophils.
No, neurophils.
Oh, so we are going to
As
see
we also see the synaptophysin.
yes, synaptophysin, which are specific. Okay, synaptophysin are basically like present, or they are basically like intermediate filaments present within your neuron. So we are going to see neurophils surrounded by these blue cells or tumor cells, right? They are basically known as Homer right rosettes. Is that clear?
Yeah.
Okay.
And it's also absent of lumen. It doesn't have
Okay.
lumen.
Okay. Yes. So sometimes we can see like neurophils, or sometimes it can be empty, right? Nothing present there. Okay. So let's discuss our next tumor, that is ependymoma, right? So you guys are already aware of ependymoma. It's age group. So you guys are going to come.
I'm sorry, could you repeat that? You said it's going to be neurophil surrounded by what?
Okay. So these tumor cells are basically going to surround these neurophils, right?
Okay.
Is that clear? The tumor cells. Okay.
All right.
So we have ependymoma. We already discussed that ependymoma are again malignant tumors seen in children, right? Is that clear?
Yes.
Okay. So ependymoma basically, like it would arise from the, like most commonly it arises within the fourth ventricle, right? Because we already discussed in our anatomy that all of your ventricles are like inside are basically, lined by ependymal cells, right? So whenever it arises from the fourth ventricles, it can also cause hydrocephalus, right? For example, if the tumor enlarged, it can compress the foramen Lushkas, the Magendie, and in turn it could lead to non-communicating hydrocephalus. Is that clear? So you should only think of, ependymoma arising in fourth ventricle causing hydrocephalus. Is that clear? Hello?
Got it. Yes. Sir.
Dr. Ahmed, I have a question. Is it communicating or non-communicating hydrocephalus?
Okay, so if we have we have like a fourth ventricle being compressed. So are all of these ventricular system communicating or not? Yes or no? What do you think?
Non-communicating.
Yeah, so it would be non-communicating hydrocephalus, right? Whenever the fourth ventricle is involved. Okay, so let's discuss our last tumor, that is craniopharyngioma, right? So you guys are already aware of craniopharyngioma. Basically, we have an oral epithelium, that is Rathke's pouch. Rathke's pouch would just come, it would join with the posterior pituitary, and it would just form the anterior pituitary, right? The Rathke's pouch. So sometimes what happens, this Rathke's pouch can develop, like a tumor that is known as craniopharyngioma. It is basically seen within children, right? And whenever this tumor just comes here, it can compress the optic chiasm, right? We already discussed this tumor in our endocrine module, if you guys remember. And whenever
Yes.
the optic chiasm is compromised, so which deficit are we going to see? Yes.
Bitemporal
Bitemporal
hemianopia.
hemianopia.
Yeah.
Perfect. Bitemporal hemianopia. And if you just resect this craniopharyngioma, it would be having, like cholesterol within it, cholesterol, or simply it's also known as like, machine oil like consistency, right? So it would be like a yellow brown kind of stuff present within the craniopharyngioma or within this tumor, which is like, filled of cholesterol. Is that clear?
Yeah. Mhm.
Okay. So with this, we have finished our tumors, and I think it was an easy topic. So now we'll be discussing the special senses, that is eye, right? So we are almost like done with neurology, and we are just left with the special senses. So we'll be discussing eye today and tomorrow, and then right after that we'll be discussing ear. Like you have a lot of MCQs on that. So most of the students like find it very difficult, right? Because it's mostly going to be tested on your step 2, but you have some information which you guys must know, right, regarding your special senses. So let's discuss first of all our eye, right? So before discussing eye, let's discuss the normal anatomy of your eye, right? So I think most of you guys would know the anatomy. So you guys are going to help me with that. I'll be just drawing the structures, right? So for example, if this is your eye, okay, right? So we already know that optic nerve is going to come here. You have a central retinal artery and central retinal veins, which also comes through this along with the optic nerve, and it would just form an optic disc, if you guys remember, right? Optic disc. Okay. What else? The anterior part of this eye, basically, it's known as cornea, right? Are you guys getting me? Hello?
Yes. Yeah. Yes.
Okay. So we have cornea, and basically we have like our sclera, which is the outermost, and below the sclera we have our choroid plexus, which are basically going to give blood supply to our retinal layers. Like you have your choroid plexus, which are going to come here like that. And you guys already know that in the posterior segment, we have our vitreous humor, right? That is a gelatinous substance present in the posterior aspect of your eye, right? So you have your choroid, your sclera, and then you have a layer of retina, right? Which is the neuronal layer. We have a lot of rods and cones here in order to see, right? So we'll be discussing that in a while. So we have retina, we have our vitreous humor, and here, if you guys remember, we have our ciliary bodies. We have our ciliary bodies, we have iris, right? So these are our, okay. So we have our ciliary bodies, our iris, and we have our pupil, right? This empty space is your pupil, right? And we have lens as well, if you guys remember, right? So we have our zonales here. We have a thread-like structure, which would basically, we have our suspensory ligament through which our lens is attached. You guys already know that, right? Are you guys getting me? So you have our lens, and you have our zonules, which basically, helps in accommodation. So can you guys just tell me what is accommodation? Yes?
The ability of the lens to focus on near and far objects.
Okay. Okay. Like, for example, if I have something like, for example, if I'm just seeing far, right? Let's suppose if I have a pencil and this individual is just focusing on that. Let's suppose if I'm just bringing this pencil near, so what happens? We are going to have an accommodation reflex. So what is accommodation reflex? Basically, the pupil is going to constrict. So if you guys remember that we have a specific area within the retina, which is known as fovea. Are you guys are you guys aware of that? Fovea.
Yes.
Okay.
Yes.
So the fovea is basically, the part of your retina where you can see the maximum appearance of an image, or where the visual acuity can be assessed, right? So all of the structure which we see mainly falls on your fovea, right? So most of your visual acuity is basically dependent on your fovea, right? And surrounding the fovea, we have a structure which is known as macula, right? So the surrounding area of your fovea is basically known as macula. Okay, just give me a second. Are you guys getting me? Hello? Hello?
Yes.
Yes.
Okay.
Yep.
So for example, let's suppose if this individual is seeing, let's suppose if I'm just bringing some object near to his eye, so we already know that this object is going, okay, so this picture is mainly going to fall on your fovea, right? Which basically gives you the maximum visual acuity of a certain object, right? And what happens if you are just bringing it near? So what would happen to the lens? Would it condense, or would it, what would happen? Would it flatten, or would it become more spherical if I'm just bringing an object near? Yes. What do you guys think? It would become more spherical. Why? Because yes. So what happens? Whenever we are bringing an object near, so what happens? It would become more spherical. Why? The refractive index. Hello.
Yes.
Okay. So in accommodation reflex, basically we are going to see two things. First of all, we are going to see pupil being constricted. Why are we going to see constriction of pupil? Because we want the image of this object to fall on the fovea. That's why we are going to have constriction of your pupil. What else we are going to have? Like spherical arrangement of your lens. Why? In order to increase the refractive index. As we know, whenever the lens become more spherical, so it would just refract a lot, right? So the refraction basically increases, and again it would have to create an image on fovea again, right? So the diffraction is increased, and once the diffraction is increased, it would have the image to fall on fovea in order to have maximum visual acuity. Is that clear? So we are going to see two things, that is pupillary constriction and densening, or we can say that spherical configuration of your lens. And what is basically the importance of both of these two phenomena in accommodation reflex? In order to give maximum visual acuity, or in other words, in order to create an image on fovea, which is basically responsible for your maximum visual acuity. Is that clear? Hello?
Yes. Yes.
Yes.
Okay.
Yes.
Okay, perfect. Okay, what else? We already know that we have something called as aqueous humor. So what is aqueous humor? What do you guys think? Yes.
It's like filtered blood in the eye.
Okay. So basically we have we have vitreous humor, which is basically present within the posterior segment. We have aqueous humor. So aqueous humor is basically, you can simply imagine it as a liquid kind of substance which is being released by your ciliary bodies. And what would happen? This liquid aqueous humor would just go from the posterior chamber to the anterior chamber, right? And in the anterior chamber, what would happen? Here you have a junction which is known as iridocorneal junction, and in this junction basically we have something called trabecular meshwork, and behind the trabecular meshwork we have a canal which is known as canal of Schlemm. So all of this aqueous humor through that trabecular meshwork is going to drain into canal of Schlemm. Is that clear? And from the canal of Schlemm, it would just enter the episcleral vessels. So we have sclera here, and we have blood vessels. So this is the normal pathway of your aqueous humor, right? So basically, this is your posterior segment, and this is basically your anterior segment. So the anterior segment is further divided into anterior chamber and posterior chamber. So in the posterior chamber, let me just repeat it again. Your ciliary bodies are going to form aqueous humor. That aqueous humor from the posterior chamber is going to enter into anterior chamber. And in iridocorneal junction, we have something called trabecular meshwork. It's simply a meshwork which is present. Simply you can just think of, we have some filter there, right? Like a filter kind of meshwork, right? So this aqueous humor is going to filter through that meshwork. Then it's going to enter into a canal, which is known as canal of Schlemm. And from the canal of Schlemm, it's going to enter into episcleral vessel. Is that clear? This is the normal pathway of your aqueous humor. Is that clear? Hello?
Yes. Yes.
Okay, perfect. So we have some pathology which is associated with increased intraocular pressure. So what do we mean by increased intraocular pressure? Yes. Yes.
Because of improper drainage of the aqueous humor.
Perfect. If we do not have proper drainage of the aqueous humor, like for example, if we have problems here with the trabecular meshwork, let's suppose these filters are closed. So what happens now? We cannot, drain your aqueous humor. If the aqueous humor cannot be drained, what happens? It would just keep on accumulating within your eye. And if it keep on accumulating within your eye, what would happen? It would increase the pressure within your eye, which is simply known as increase or intraocular pressure increases within the eye. Why? Okay, one of the reason was if you have problems with the trabecular meshwork, right? The angle is open. You guys can see the angle is open, but what happens? You have problems with trabecular meshwork, or simply you can imagine of that the filters are closed. You have something which is, like closing the filters, right? So in that case, we are going to have increased intraocular pressure. So if the intraocular pressure increase, what would happen as a result of that? Remember, whenever the intraocular pressure increase, it would just, it would just increase the force, or it would or it would just compress your optic nerve. And once optic nerve is compressed due to this increased intraocular pressure, the neuronal component of your optic nerve would slowly start degenerating. And once, due to increase in intraocular pressure, if it compresses your optic nerve, which leads to degeneration of your neurons, it's known as glaucoma. Is that clear? So what is glaucoma? Glaucoma is simply the degeneration of your neurons within the optic nerve, right? So on fundoscopy, for example, you are going to see the optic disc like that, right? So this is going to be your optic disc, and you are going to see like neurons here, right? Coming out of that optic disc on fundoscopy. So if an individual is having increased intraocular pressure, it can lead to degeneration of these neurons, right? So we have something called cup and disc. So you guys can see this is your, let's suppose your disc, right? And this is your cup. So the cup basically have pure neurons, right? So whenever in glaucoma, whenever you have degeneration of these neurons, so it would increase your cup to disc ratio, that the cup is going to be more like that if you have degeneration, right? So like if the central part, as I discussed, for example, if this is your cup, right? Cup have pure neurons, right? And this is your disc. So basically the neuronal component within the disc are going to degenerate. So if the neuronal component within the disc are degenerating, so it's obvious that the cup width would increase. Is that clear? So can I say that the cup to disc ratio would increase in glaucoma? Can I say that?
Yes.
Perfect. Yes. So what is the characteristic features of glaucoma? The cup to disc ratio increases, right? So there are two different variants of glaucoma, right? One is known as open angle glaucoma and other is known as closed angle glaucoma, right? Open angle and angle closure glaucoma. So this variant which we discussed, that the angle is although open, but we have problems with the trabecular meshwork due to which the aqueous humor cannot drain. That's simple known as open angle glaucoma. So we have another variant as well that is known as closed angle glaucoma. So let's discuss closed angle glaucoma. What happens in closed angle glaucoma? As the name indicates, the angle would be closed. So how do we get closure of that angle? So let me just draw the eye structure again. For example, this is your cornea, your sclera. Back here you have your optic nerve, your vessels. We have our choroid plexus, like that. And then we have our retina here, right? So, for example, these are our ciliary bodies, your suspensory ligaments, zonules, and this is your, let's suppose, your lens, and these are going to be your iris, right? Your iris. So sometimes what happens, for example, sometimes the iris or the pupil would dilate, right? So due to, like, okay, so the closed angle is basically due to anatomical defect, remember. So sometimes what happens that, for example, it can be due to certain drugs, for example, atropine, right? We're already aware of that. You have a UWorld MCQ on that. Whenever we just give atropine, it would lead to maximum dilatation of your pupil. And as a result of that, what happens? The iris is going to, attach to the anterior surface of your lens. It would attach to anterior surface of the lens. So now what would happen? All of the aqueous humor cannot just drain. If we have attachment of the iris here to anterior segment of the lens, so the aqueous humor cannot drain, right? It cannot drain here to the iridocorneal junction. And what happens? This iris is further going to block off this pathway. Or in other words, it's going to close the angle, the iridocorneal junction. Now again, we cannot, move this aqueous humor into trabecular meshwork, canal of Schlemm. But now here it is due to closed angle. Why? Because the iris is attached to your lens, which decreases the angle, which closes the angle. And again, now the intraocular pressure again increases. If the intraocular pressure increases in closed angle glaucoma, again, it would compromise your optic nerve. And again, we are going to have increased cup to disc ratio. Is that clear? And it would lead to glaucoma. Is that clear? Hello?
Yes, sir.
Okay, perfect. Okay, so this was all about glaucoma. Let's discuss some of the, refractive errors, right? So we have a lot of refractive error. We have hyperopia, we have myopia, and we have astigmatism, right? So the first one is hyperopia. So what happens in hyperopia, remember, normally we know, for example, if this is our eye, right? We have our cornea. We already know that, for example, if we have an image falling, it would just focus on the fovea, right? On the retina, specifically on the fovea of retina, right? So what happens in hyperopia? In hyperopia, basically we have short, or we have the eye is very small, right? You have short. The axis of the eye is very short. So what happens now when the image is falling, the image would just fall behind the retina, right? It would just fall behind the retina somewhere here. Why? Because now the orbit or the eyeball is very short. Are you guys getting me?
Yes.
If the eye, it's also known as farsightedness. That is, we can see the far objects, but we cannot see near objects, right? So what happens due to short eyeball? What happens that now the image would just form behind the retina. If I want the image to be focused on the fovea in case of hyperopia, so here's a question for you guys. Which lens I have to use? Convex lens or concave lens? Yes.
Convex.
Why not concave? So we discussed that we have convex lens, and in convex lens, we're already aware that the diffraction is very high. That is the refraction, right? The refraction is very high. It's going to diffract. Diffraction is simply bending of the light, right? Bending, right? So what happens? The refractive ability of a convex lens is very high. So it would just tend to, it would just tend to move forward this image, and it would just bring it back to your fovea, right? So we are going to use convex lens. Why? Because due to increased refractive index of these convex lens, it would just try to bring the image in front, that is on the fovea, and the vision is going to be corrected. Is that clear? Hello?
Yes, sir.
Perfect. So we have another condition which is known as myopia. So what is myopia? Myopia is also known as nearsightedness. That is that in this case, we are going to have too long eyeball, right? The eyeball is going to be very long. So what happens now as a result of this long eyeball or this big eyeball, what happens? Now the image would be formed in front of fovea. It won't be again on the fovea or on the retina, I can say, because fovea is the part of retina, right? So what happens that now the image would be in front of your retina or fovea. So in order to correct this condition, which lenses am I going to use? Yes, Convex lens or concave lens?
Concave.
Concave.
Okay, we have
Concave.
yeah, concave lens, because it's going to, like you have decreased refractive ability of concave lens, and it would just push back this image on the fovea, and in this way it can help, right? So for example, if okay, let me just tell you an interesting fact. For example, if you have an individual, he's like myopic, right? And let's suppose he become like he's now like 60 year of age. Like when he was a child, he was myopic, but at 60 year of age, he, like, for example, he was just using concave lens, right, throughout his life. Okay, just give me a second, I don't know what happened. Okay, so for example, this individual was using concave lenses, right? But once he was 60 year of age, he just threw his glasses and he was saying that now my vision is perfect. Do you guys know that? An individual with myopia, as he ages, what happens? His vision would be corrected. He won't be using the glasses anymore. What do you guys think? Why?
Collagen is reducing, so the eyeball is reducing in size, and then the image can now form directly on the fovea of the retina instead of forming before it.
Okay. So, okay, let me just ask you a question. Whenever an individual age, there is a phenomena which is known as something press. Yes, what's the name of what's that?
Presbyopia?
Presbyopia.
Presbyopia. Yes. So, what is presbyopia, by the way? That is the accommodation reflex is going to be lost. And what happens when the accommodation reflex lose? What happens? The collagen component of the lens is going to degenerate, right? So the refractive ability of the lens with age decreases due to degeneration of that collagen, which was priorly important for your refraction. So with age, your lens simply turn more into a concave lens. Are you guys getting me? Why? Due to degeneration of the component, now it cannot refract well. So if the refractive ability is decreasing with age, so it would somehow be same as that of concave lens, right? With age. Are you guys getting me?
Could you come again, please, Dr. Ahmed?
Sorry?
Please, could you repeat the
Okay, I'll
presbyopia?
just repeat it. Okay, okay, with age, what happens that normally we have lens, right? So lens have its nucleus, it have cortex, we have a lot of collagen fibers, simply you can think of, right? Which basically give it a structure, that transparent structure, and it's a transparent lens, and it have increased ability of refraction, right? So with age, what happens? We'll be knocking off this collagen, right? If you're just knocking off this collagen, the refractive ability is going to be decreased. Are you just getting me?
Mm-hmm.
If the refractive ability is decreasing, so can I say that it would somehow act as a concave lens? Because in concave lens, the refraction is very, refractive index is less as compared to, okay, it would more resemble as concave lens, so not convex lens, right? Are you just getting me?
Yes, you said concave. Mm-hmm.
Yes, it would more be that of like concave lens. Why? Because the refractive index is decreasing, right? Due to degeneration of the collagens.
The
Are you
collagen.
getting me?
Mm-hmm.
Yes. So if the refractive index is decreasing, it means now it would be acting more as a concave lens, right? So you already know that the treatment for these individuals are concave lenses, right? Hello?
Yes.
And
Yes.
with age, normally your lens is acting as a concave. So with age, what happens? His sight would get improved. Is that clear now?
Mm-hmm.
Okay, perfect.
Thank you.
Okay, so we discussed glaucoma, we discussed aqueous humor pathway. So let's discuss some of the drugs, right? So you guys are going to tell me, for example, if I want to decrease the production of aqueous humor, so which drugs are responsible for that? Which drugs decreases production of your aqueous humor from your
That's maybe.
okay, beta blocker, specifically which beta blocker? You have a word MCQ on that?
Timolol.
Perfect, timolol, right? What else? Alpha 2
Alpha 2
agonist,
agonist. Yeah.
and carbonic anhydrase inhibitors as well.
Yes.
Okay, perfect, right? So you guys should know these drugs. They're very important. We'll be having a keyword MCQ, right? So this was all about glaucoma. We discussed, okay, let's discuss lens disorder, right? So we discussed we have a phenomenon that is known as presbyopia. So what is presbyopia? As we already discussed, presbyopia is basically, it's an age-related impairment of accommodation reflex. We already know that. That is, your lens would just become stiff, right? The accommodation capability of the lens would decrease. And what else? The lens elasticity is also going to be decreased. That is, we discussed that the collagen component of the lenses are going to be degenerating. The refractive ability of the lens also decrease with age. That is simply known as presbyopia. Is that clear? So we have another term used, that is cataract. So what is cataract? Can anyone just tell me?
Opacification is like opacification of the lens. Something like
Perfect.
that.
So whenever the lens become more opaque, right? So it's basically known as cataract, right? So there are a lot of causes of cataract formation, right? Like with age, if an individual is increased to sunlight exposure, it can normally cause, cataract, right? With age. So it's a normal phenomenon with aging. But what things increases the formation of cataract, right? So that is, remember, glucocorticoid use. You guys are already aware of that. Like in ophthalmology, most of the the doctors basically prescribes the glucocorticoids, which just relieve the symptoms. For example, if someone is having allergic conjunctivitis or things like that, but it's not all like it's like not like we won't give like glucocorticoids. It's very common in practice giving glucocorticoids, right? Why? Because it increases the chances of formation of cataract. That is, like for example, if this is your lens, remember, administration of glucocorticoids increases the cataract formation, though, that is opacification of your lens, right? Similarly, diabetes can also increase the likeliness of having cataract at early ages. The torch infections, we are already aware of that. Alport syndrome can also increase the like chances of having cataract, right? So these were cataract, and what would be the presenting features? An individual would just experience like a glare or hollows within the vision, right? So like for example, if this is the light source, so the light source would just appear like very like hazy kind of, right? Whenever an individual is having a cataract, and the red reflex is also going to be lost. So can anyone tell me what is red reflex? Yes, what is red reflex?
This is the reflection of the retina pigment on the eye
Okay,
exam.
okay, so whenever in the eye examination, we are going to have red reflexes. That is basically whenever the blood component or the choroid plexus, whenever we shine light on that, we are going to have a red kind of, like reflex. The eye is going to appear red. So whenever we have opacification, what happens? The red reflex is basically lost. The idea is really clear. The light cannot, like reflect back through that opacified like lens, and it would lose the red reflex. That is, we are going to have a kind of reflex that is white reflex. Okay, so what is the term used for white reflex or whitening of the eye? Whenever we just like on the eye examination, if you are just seeing whitening instead of red reflex, what's the term used for that?
Leukocoria.
Leukocoria, perfect. As we know that the term leuco means like we have leukocyte, white blood cells, right? So leukocoria means that the whitening of the red reflex. Normally it should be red, right? Is that clear?
Yes, doc.
Okay. So, okay, so, okay, what's the time? So I think it was all for today. And tomorrow we are going to finish off our eye module. And we are only left with a little things. We all like tomorrow we'll be discussing the cranial nerve, its policies. We are already aware of that, but we are going to have a quick overview. And besides that, we have an important discussion, that is retinal disorders, right? So tomorrow we are going to discuss diabetic retinopathy. We are going to discuss age-related macular degeneration. So you guys should be there in class, right? Hope so you guys enjoyed this session, and see you tomorrow, right? So you guys are already aware of that. We have just met the group, and those who have, Dr. Daniela already shared the poll, and those who are giving their exam in the upcoming 1 month or 2 month, we have already started, adding them into the group, and we'll be, separating their task. They'll be like in their accelerated phase. So please do join that group. And before separation of your tasks, you guys are going to give an NBME, right? So we are planning that next Sunday, those individuals who are about to give their exam within 1 month or 1.5 months, first of all, they'll be giving an NBME exam, right? So looking towards their NBME scores, then we are going to, accept them whether they are eligible for that fast-paced study or not, right? So for you guys, those who have joined that group, so this week, we have planned that we are going to share them tasks, and there would be like a quick kind of task, right? So you guys are going to wind them up within a little time span. And what else that, first of all, you are going to give NBME. So next Sunday, you guys are going to give NBME, and looking towards that score, then we will decide that either you are eligible for that program or not, right? Hello, is it clear?
Yes.
Yes,
Oh,
Doc.
okay. So hope so you guys enjoyed this today module, and you guys are already know that in the last days we were more focused on discussion of Flu World, because those topics are better to be discussed from Google. But from now onwards, we are going to take our normal classes as we did, and we are also going to have a bootcamp session right after we are done with ENT. Like we have an I module going on now. You guys are already done with Neuro, by the way. Congrats, right? So once we are done with the special senses, we will be having a combined bootcamp, and we are also going to discuss a lot of UWorld MCQs in that, because for this module, the UWorld covers a lot of things, right?
Yes.
Okay. So thank you so much, and see you tomorrow, right? Thank you.
Thank you, Doc. Appreciate it.
Thank you, Doc.
Thank you.
Thank you, Doc.